have the next important but very less paid attention to session, male infertility, because it's a patriarchal society. We always stay in persistent denial. We refuse to accept that it can happen. So sir will be talking about male infertility, diagnosis and awareness. And for this, and Dr. Rijo would be talking about this. Sir is the secretary of Kerala IRIA, a very dynamic person. And like Kanusha ma'am explained earlier, she is the live wire of Kerala IRIA. He is the founder of Samrakshan, which was conceptualized by him. He is the chairman of Insta Specialty Hospitals, Kochi, chairman and chief radiologist at Amma Center for Diagnosis and Preventive Medicine. And he is the mentor at Amma Healthcare Research, Gurukul, Kochi. So again, sir is going to shed some light on this less talked about area, the male infertility. Sir, over to you.
Thank you, Dr. Avani. Let me share my screen. Is my screen visible now?
Oh, sir, it's just, yes, sir, it is.
Yeah. Just move on to the slideshow mode. Is it in the slideshow mode now?
No, sir, it's still in that thumb. Yes, sir. Now it is in slideshow.
Okay, right. Okay, so thank you, Dr. Avani, and we have heard quite a lot about the infertility aspects of Dr. Soumya Dwivedi and Dr. Priya giving a larger perspective on the male and female infertility. And later on, Dr. Ritu Lokande giving a description about the polycystic ovarian syndrome, and then Dr. Gaumadi ma'am giving a detailed interview on the role of nutrition in infertility. So my role here is to talk about the male infertility, which is often a component that is usually ignored. But in fact, infertility, the causes, when you consider the causes of infertility, it can be nearly 30 to 40% causes can be from the male partner. But still that awareness is very limited. That is why, as in the first session that they said, most of the time when the ladies are usually brought, the females are usually brought by their in-laws or their parents for the infertility workup. The guy never turns up. But now, at least in urban setups, we see the couple coming together for a workup. But then in the rural areas, it's still not a practice. But in fact, the evaluation has to be done for the couple, for the female part, for the male part, because causes of infertility can be a female factor, can be a male factor, or can be a combination of both. So the my slides are not moving. I shall stop sharing, and again I'll come back with the. Shall share the screen again, I think.
Okay, sir.
Okay. So here is a 38-year-old couple, a male being male infertility being worked out, and a case of azoospermia, where one of the investigations that we do is a transrectal ultrasound, and we see a large, because this is a patient, the couple had undergone the couple had undergone 2 ICSIs and had failure. but then the male factor was not well investigated. But we did the workup for the male, and we saw he has got azoospermia, and there is a large cyst, and it is an ejaculatory duct cyst, and we did the aspiration and found sperm in that. And later on, that was deroofed, and after 4 months, its sperm count improved, and after 6 months, its wife got pregnant. So the thing is, most of the time, even in an IVF center, the male infertility, male workup is often ignored. And that has got two important issues related to that. One is correctable cost may not be identified, and without much expense, we may be in a position to solve get the pregnancy. And another thing, when there is an azoospermia or oligoastinospermia, or the problem male factor is the quality of sperm also has got some problem. Even if you're trying a in vitro fertilization using a technique called PESA or TESA by intratesticular aspiration or so, because the quality of sperm, there is a concept called reactive oxygen species. That is, because of the superoxides and peroxides, that the oxygen free radicals that develop, which can cause significant damage to the DNA and the protein in the sperm. And the quality of sperm can be really bad, not good. And the embryo development and even problems in the, even diseases can appear because of that. So considering these two factors, I think male infertility has to be worked up properly. And there I'm going to highlight on some essential investigation the radiology provides there, which has not been highlighted much. So male infertility, the contributing factors can be low sperm production, abnormal sperm function. There can be a blockage that prevent the sperm delivery. There can be chronic health problems, injuries, and lifestyle choices, all of which have been already mentioned here. And the main sign of male infertility is inability to conceive a child. There may not be any obvious signs. That is one of the reasons why male doesn't turn up and thinking that they have got nothing to do with this. In some cases, however, an underlying problem such as an inherited disorder or hormonal imbalance or dilated veins around testicle, which is otherwise called as a varicocele, which is a common cause, and there are conditions that can block passage of sperm, causing signs and symptoms. There can be another important cause as a part of a workup is problems with sexual function. There can be erectile dysfunction, there can be ejaculatory disorders, difficulty with ejaculations, or the volumes of fluid ejaculated or may be less, the reduced sexual desire may be there, or there can be difficulty in maintaining erection, that is an erectile dysfunction. So that also can be a major cause of infertility. Any patient who has got a pain or swelling or lump in the testicle area also has to be investigated. So when to see a doctor if you have been unable to conceive a child after a year or so, after unprotected intercourse, or sooner, if you have erection or ejaculation problems, low sex drive, or and then if you've got pain, discomfort, a lump or swelling in the testicle area, a history of testicle, prostate or sexual problems, a groin, testicle or scrotum surgery, and a partner over the age of 35, all should definitely see a doctor for the workup. So I'm just going to highlight about what are the conditions where imaging plays an important role in male infertility, the role of radiologists in male infertility. It can be, as semen analysis already been mentioned by Dr. Priya and Dr. Soumya. So when in the semen analysis, hormonal workup, and then the imaging test. These are the three areas where we have got we can work up the male infertility. Oligoastinospermia. Oligospermia is less sperm, but astinospermia, the shape, the teratospermia, and azoospermia, there may not be any sperm at all. Low volume ejaculates, absent fructose, especially when there is a seminal vesicular genesis, a seminal vesicular aplasias, there can be absent fructose in the semen analysis, and that may be one of the reasons that may be contributing to male infertility. Absence of coagulation. Again, when you do the semen analysis, just not the number of sperms or the motility alone. There are other factors in the semen analysis also to be considered. If you see an absence of coagulation, that's a sign of an ejaculatory duct obstruction. And prolonged or absent liquefaction, poor prostatic secretion, or no liquefaction enzyme. That's the clue for if you see the prolonged or absent liquefaction. And the reddish color in sperm is hematospermia that has to be investigated for chronic prostatitis or ejaculatory duct cyst or ejaculatory duct calculi, etc. So the two radiological tests modalities that are extremely useful is a high-resolution ultrasound and color Doppler of the scrotum, and also a transrectal ultrasound for the evaluation of prostate and the seminal vesicle and the ejaculatory system. So basically, with the high-resolution ultrasound and color Doppler, you are looking at the testicular volume and echogenicity. Look for the epididymal cysts, obstruction, infections. And the third important component, the very important component that you're evaluating is a varicocele, which is a very common one that can cause significant oligoasthenoteratospermia and also reduce the quality of the sperms. It is a correctable cause, especially with procedures like microsurgical varicocelectomy, which can cause, give good quality sperms, and it can improve the semen analysis at a later stage. Other test is transrectal ultrasound. Is again ultrasound. With the help of transrectal ultrasound, we can evaluate the prostate, the seminal vesicle for seminal vesicle agenesis, or a vasoaplasia, both in cases of azoospermia, ejaculatory duct obstruction, or chronic prostatitis. So the workup of azoospermia, if we are seeing any congenital cause that requires is confirmatory for some kind of different kind of intervention that is possible, and that is essentially required. Another cause of male infertility can be a part of the male orgasmic dysfunction. Organic causes and psychogenic causes of erectile dysfunction can be there. So the penetration, the consummate marriage might not have been consummated, penetrated sex might not have happened, and there can be the female component also, like vaginismus and even the erectile, and then the male component of male problem of a erectile dysfunction and their inability to do a penetrative sex. Ejaculation and orgasm occurs simultaneously. So there is another important ejaculatory disorder which is very common when you analyze the male infertility patients is premature ejaculation. So premature ejaculation can occur during the foreplay, which can be a cause of infertility, or even during the vaginal or a penovaginal touch can be a cause of infertility, because the sperm doesn't reach the uterus. Then immediately after penetration or ejaculation before the partner gets orgasm, all these are causes of premature ejaculation. Then the delayed ejaculation with orgasm, this also may lead to infertility. Absence of ejaculation, the presence of orgasm, that's an orgasmic anejaculation it is called as, and there is another entity called as retrograde ejaculation, where the sperm will go into the urinary bladder rather than coming antegrade. So these are all the causes of infertility. Anorgasmic ejaculation. So ejaculatory disorders and erectile dysfunction also can be a contributor for male infertility. So there are studies, the help of penile color Doppler ultrasound studies, we can understand the cause of erectile dysfunction and whether there is an arteriogenic cause or whether there is a venous leak or a veno-occlusive dysfunction. In those cases, the management changes. The 80% of premature ejaculation patient has got a association with chronic prostatitis. This is a finding that our center has come out, and that is increasingly, if we can treat this premature ejaculation with the treatment of chronic prostatitis, there is a significant improvement in the semen quality too. Diseases now coming, there can be congenital causes of obstructive azoospermia or obstructive causes like agenesis or hypoplasia of seminal vesicles or ejaculatory ducts or distal vas deferens. It can be unilateral or bilateral. There can be cysts of the seminal vesicles, ejaculatory ducts and distal vas. There can be stenosis of the ejaculatory ducts and distal vas deferens. There can be hypoplasia of prostate, so there may not be enough volume of the ejaculate. because prostatic secretions form the major component. The prostatic utricle cyst, again causing an obstruction to the ejaculatory duct, and then there can be acquired diseases like in autonomic and somatic nerve damage in the pelvis by pelvic trauma, spinal cord injuries, operations, prostate and bladder neck surgery, stricture urethra, and operations on urethra. All these things can cause male infertility. What I am showing here is it's a Prader's orchidometer. That is one of the instruments used by the andrologists and urologists to assess the testicular volumes. In the previously before the ultrasound became the modality to look for testicular volume. So with the help of ultrasound, now we can assess the testicular volumes very clearly. And we did a study in comparing a Prader's orchidometer assessment versus a testicular volume assessment with ultrasound. And there is a difference of 5 ml between Prader's overestimates, because of course the skin and the subcutaneous tissue, all these things are considered in Prader's. It just compares the testicle, it holds the testis and then compares it with this particular size and then say that it's 20 ml. But when it is a 20 ml on Prader's, it usually will be 15 ml on testicular ultrasound. Other causes of obstruction like epididymal cyst obstruction, epididymitis, all these infections again can cause decreased quality of the sperm. So this has to be can be easily detected with the help of high resolution ultrasound. And epididymal duct obstruction, this is a very important cause that has to be differentiated with the help of a high resolution ultrasound. When you see tiny cystic tubular lesions, especially in the rete testis, those are indications of epididymal duct obstruction. Again, when you work up azoospermia or oligoastinospermia, this can be important. In intratesticular varicocele, again, varicocele evaluations I've already mentioned that varicocele is pretty easy to diagnose. The patients has to be evaluated in standing position because that's how the andrologists or the clinicians see them. And if you see only on the lying down position, you may miss some mild forms of varicocele. And it's always essential to evaluate them in standing position and ask them to do a Valsalva maneuver on in standing position. You will see an increase in the diameter of the pampiniform plexus, and grading of varicocele especially has got severe varicoceles or even milder forms of varicocele also has significant. It is better to correct them for good quality sperms and in the workup and evaluate management of male infertility. Showing a few cases of hydrocele and varicocele serum. Testicular microlithiasis is another condition where you get calcification in the seminiferous tubules, and it's a premalignant condition but can cause oligoastinospermia to azoospermia. The other investigation I've already mentioned is a transrectal ultrasound for prostate, seminal vesicle, ejaculatory duct, and vas deferens. Transrectal ultrasound is commonly used by most of the radiologists for evaluation of prostate, for benign prostatic enlargement or prostatic malignancies evaluation. But in infertility, the role is not only limited to prostate. You can evaluate the seminal vesicles, you can evaluate the vas deferens, you can evaluate the ejaculatory duct, and those are the areas that you need to focus on. So in the seminal, this is a picture of seminal vesicle and the vas deferens, the distal vas deferens. In the seminal vesicle is seen as a bow tie appearance, and below that you are seeing the distal vas deferens. So there can be conditions where there can be seminal vesicle agenesis or aplasia, or even vas deferens aplasia or vas deferens agenesis. So this is a case where the prostate was normal. There's workup of azoospermia, and on transrectal evaluation we can't see the seminal vesicles properly, and in one case, from the right side, you can see a hypoplastic seminal vesicle, and on other one, you can see a unilateral hypoplastic seminal vesicle. So there can be different variations which will be contributing to the semen analysis semen analysis patterns and towards infertility, male infertility. So the tests that I've already mentioned is essential to focus upon this workup of male infertility with the three radiological tests I've already mentioned is high resolution ultrasound and color Doppler of scrotum. And then the transrectal ultrasound for prostate, seminal vesicle, ejaculatory duct, and this and vas deferens. And then penile color Doppler studies for erectile dysfunction. So these are the 3 studies that are essential in the workup of male infertility. If you come across any obstructive pathologies, it can be easily picked up and can be corrected to before going in for IVF, and especially techniques like TESA, PESA and all, where your intratesticular or percutaneous aspirations of whatever limited quality of sperms are available. But again, before embarking for such procedures, I strongly recommend to go for the imaging evaluations of the male if any of these factors, correctable causes are there. Yes, because this concept of reactive oxygen species contributing to DNA damage and at different levels of DNA defragmentation, mitochondrial DNA damage, telomere attrition, and then causing an oxidative stress on the semen quality, on the sperm quality, which in such low quality sperms, if you are using for IVF, again, there can be problems with for embryogenesis as well as for the implantation, and also can have problems with the offsprings too. So thank you very much for a kind attention. I think I'm through.
Yeah, thank you so much, sir. Like sir said, one thing is people are not much aware of it. And even the modalities that sir has suggested, it is mainly specialized people only do it. Scrotal ultrasound, yes. But the spenile Doppler and transrectal ultrasound, again, there are limited places. Maybe that is also one of the reasons, and fear of the procedure itself. So I think people should learn the importance of what all they can get out of the procedures, and that will reduce the inhibitions in going through that. So next, if there was one question that we had, it is a general question. So shall I take it now? It's from one of the attendees.
Yeah, Dr. Rijo can answer it.
Okay, sir. It is basically an attendee who has asked it. I would like to obtain an opinion of all the distinguished doctors here. I am Chitra, 32 years, and I have had 4 spontaneous miscarriages in the last 3 years. 2 natural conceptions, 1 and all done. The doctors in Bangalore have done uterine scans, blood tests with the whole spectrum, APLA, NA, HbA1c, prolactin, karyotyping was done. So everything was normal, and they want to know if there's any further tests that can help us find an answer to the problem. So very practically everything has been done. But if still we want to add it to
I think a male factor workup with imaging is still missing there.
Yeah, even I thought of that.
I think she mentioned that both have been worked up.
Yeah.
No.
But here,
he has not mentioned
that is a very important thing of what we were talking.
What is the semen analysis workup? What is the hormonal status? What is the results of high resolution ultrasound and color Doppler scrotum? What is the result on the transrectal ultrasound? And are there any issues of erectile dysfunction or ejaculatory disorder? So we need to get more details from them if we want to. But if none of these things are there, then the female factors have been looked into. But then a history of repeated abortions, always the antiphosphate APLA is a very common association that they've already worked out on them. And again, the the 2 common things that they've worked out for chromosomal abnormality from the parent side and APLA. Both these things have been worked out. But I still feel if the quality of the male factors has to be looked into here. If there is, because that, again, as I mentioned, if there is a poor quality sperm due to the reactive oxygen species, even though if that has not been addressed, I think again can cause a little bit of issues in their.
They would have checked the cervical incompetence also, no, for her.
Yes, and I think a morphological factor of septate uterus is also a cause of recurrent abortions. So I guess that workup would have been done. She said that imaging workup was done, but like sir mentioned, just like a pregnancy is father and mother both are part and parcel of it. In the same way, infertility can affect either side. So we have to check both the components and ensure everything is smooth. And unfortunately, there is a small percent of people also where everything is fine, and yet nature has to take its time. So though there are certain factors which cannot be answered. So yes, with that, I hope
I
you.
think
Yes, ma'am.
they should stick on to the particular place itself, and then by the trial and error, they will those centers will be able to find out what exactly is going wrong. So one of the common mistakes the infertile couple infertility workup the people do is they keep on changing. So everyone start their workup from initial this thing itself. And by that time, some conclusion is reached, or in the midway of that workup, they just change to another center. So this is a common mistake people do. And it is better to stick on to one center, because by trial and error only, they will be knowing what exactly is going wrong with the female compound factor or the male factor or a combination. And as rightly and Avani rightly said, it's not even in IVF, they say the success rate is 40 to 50% only. 50% can go wrong, even if everything else is okay. So there can be factors which may not be cannot be explained. There are.
So, like sir said,
one second, Avani. About the seminal vesicle. Suppose we are doing ultrasound. Do we mention the seminal vesicle? Because obstructive azoospermia, they say, because when there are a lot of cysts in the seminal vesicle. Will you mention the seminal vesicle in your ultrasound report?
Yes, I give the measurement of seminal vesicle. Seminal vesicle more than 1.5 centimeter at AP diameter, you have to think whether there is some kind of an obstruction developing there. And you can get seminal vesicle cysts.
Yeah.
All this has to be evaluated. And ejaculatory duct is formed by the seminal vesicle duct and the vas deferens duct. So vasoaplasia is something that we see very commonly because azoospermia workup, one of the common causes, congenital causes can be a vasoaplasia, and vasoaplasias can be at different level. Terminal vasoaplasia is one thing that you may be able to pick it up with the transrectal ultrasound, but vas is there right from the epididymis to this thing. So it can be partial aplasias at different levels, and that can cause some abnormalities.
Yeah, because this time, 2 days before only, we did a patient came with abdominal pain. Urologist referred to us for renal colic. And when we did the CT, we saw that the seminal vesicle was very bulky, more than the normal size. So we have to mention, usually we write the kidney, ureter, bladder, and foci. We never mention about the seminal vesicle. So we did an ultrasound. We found a lot of cyst in the patient, and the history told that yes, still he doesn't have a child.
No,
incidentally, we do
ask you now.
Enlarged seminal vesicle with this thing, even in case of abstinence, also they may have it.
That also yes.
Cysts within seminal vesicle, when you see, you may even have to consider possibilities of Sinner's syndrome. So what is Sinner's syndrome? It's a triad of Mullerian duct abnormalities, unilateral renal agenesis, ipsilateral seminal vesicle cyst, and ejaculatory duct obstruction. So, so you have to think of other possibilities and do workup for other systems too.
Okay. Yes. Thank you, Riju.
So I think that has covered male infertility aspect also. So we have touched base with most of the things. So I guess now that we have finished the academic session, which I'm sure everybody has found very useful, because we had a lot of information and it was reachable for even a layman. It has been projected in a way that everybody can understand. So with that, I hope this was a useful session for everyone. Now to move on to the vote of thanks, I welcome Dr. Anju Gopinath, Joint Secretary of Kerala IRIA, to kindly deliver the vote of thanks. Dr. Anju.
Can you unmute, Anju?
Yeah. A very good evening to my senior IRA members, colleagues, and dear. Infertility, even in today's times, is seen in a thing that we as doctors see on a regular basis. Most of the times, small health changes made in the couple's life with the assistance of doctors helps them to become parents they so desire for. As doctors, it's our duty to keep in touch with the latest developments in the field of female and should be given to Kerala IRA President, Dr. Gomati Subramanian, Secretary, Dr. Rijo Matthew, Academic Chairman Dr. M. Venugopal, and Program Coordinator Dr. Ramesh Shenoy for organizing such a wonderful event for National Infertility Awareness Week 2022 in association with JournoMed, MedPiper, and Dr. Swast. Our chief guest of the day, Dr. C. Shivram, Vice Chairman, Indian College of Radiology and Imaging, needs no introduction. He is very well known and revered in the radiology community. Thank you, sir, for inaugurating the program as chief guest and for being here to guide us with your words and presence. Once again, I thank you in the name of Kerala IRIA. Our amazing speakers today kept us engaged throughout their presentation and imparted us with new and improved knowledge, which is definitely going to help us to serve our patients better. A big thanks to Dr. Soumya Dwivedi and Dr. Priya Bhave for giving us a compact and informative presentation on everything you need to know about infertility and helping us confirm that many assisted treatment techniques are not unnatural and they're just to assist the couple to achieve parenthood fast. Thanks once again to both of them. Dr. Ritu Lokhande addressed the most common fertility issue that females face nowadays, and that is PCOD. Thank you, madam, for bursting the myths about PCOD and giving us an informative talk, combining both medical and holistic viewpoints. Our dear President, Dr. Gomati Subramanian, talked about the much overlooked subject in infertility, and that is nutrition. Thank you, madam, for enlightening us about the importance of nutrition and fertility, especially in children, so that we may prevent to an extent the lifestyle diseases that may be leading us to infertility. Female infertility is a common subject, but male infertility is not talked about or understood in depth. Our dynamic and vibrant secretary, Dr. Rijo Matthew, gave a very impactful talk to make us understand about the importance of addressing male infertility. Thank you, sir. I would also like to thank our zonal coordinators, Dr. Anish, Dr. Avni, Dr. Rajesh Kannan, Dr. Tara, Dr. Rashmi, and Dr. Zunimol for working tirelessly to bring us such efficient speakers. Last but not the least, I would like to thank our anchor and moderator, Dr. Avni, for making sure that the program is conducted seamlessly. Let me conclude by thanking all the participants for joining in and making this program a huge success. Jai Hind, Jai IRA.